Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS. Postgraduate Diploma in Hospital and Health Management, PGDHHM, revised. MHH 102 Hospital Services. Volume 1. Block-1 Clinical Services I. Unit-2 Accident and Emergency Services, 2.0 Objectives. After going through this unit, you should be able to explain the role and importance of the accident and emergency services. Describe the planning, staffing, and functioning of the emergency services. List of requirements in the department. Manage department in accordance with the needs and describe a plan for monitoring and evaluation of the department. 2.1 Introduction. In the previous unit you have already learnt about the outpatient services. In this unit, you will learn about the functioning of the accident and emergency department services, which is most vital, important, and sensitive component of acute medical care services provided by the hospital. In many hospitals, accident and emergency services is also called causality. The service in the department is provided round the clock, throughout the year, and it is an essential element in contributing to the health of the community. In this you will learn about the various administrative aspects of the accident and emergency services in hospitals. You will also learn about the planning of the department, along with the staffing considerations, policies and procedures required for governing the department. 2.2 Role and Functions. 2.2.1 Definitions. Medical emergency is defined as a situation when the patient requires urgent and high-quality medical care to prevent loss of life or limb and initiate action for the restoration of normal healthy life. Emergency may also be defined as a condition, determined clinically or considered, perceived, by the patient or his/her relatives, attendants, as requiring urgent medical services, failing which, it could result in loss of life or limb. An accident is defined as an unexpected, unplanned occurrence which may involve injury or an unpremeditated event resulting in recognizable damage. 2.2.2 Functions. The function of an accident and emergency depends on the responsibility assigned to it, its size, location, and type of services available in it. They are broadly described below. However, the stress on one or the other functions alters in every hospital to suit its own needs. 1. To treat and manage all unannounced patients brought to the hospital at any time of the day. 2. To deal with accidents and injuries on a 24-hour day basis. 3. To take up minor or major surgical procedure according to the policy of the hospital, with the concurrent physical facility and expertise available. 4. To prevent infectious cases from entering the mainstream of the hospital wards by treating them with proper segregation in the exclusive casualty beds. 5. To train and teach the medical and other healthcare workers. 6. A place for research in clinical medicine and other biomedical services. 7. To be used as a diagnostic and therapeutic center. 8. Handling and following up of medico-legal cases as per the law of the land. 9. Liaison with police and other statutory agencies. As already stated, the extent of its responsibility however varies in every hospital to suit its operational requirement. 2.2.3 Types of emergency services. From the professional hospital management point of view, the types of emergency services are: I. Major emergency services. The department is provided with all the major specialized facilities. The diagnostic and therapeutic facilities coupled with specialty in different categories are available round the clock. Generally, such services are provided in large teaching and tertiary hospitals. E. Basic emergency services. In this type of setup, all basic emergency facilities are available in the department and is run by General Duty Medical Officer. Round the clock, specialists in respective field are available on call duty. E. Standby emergency services. This type of emergency service is seen in PHC and Community Health Center as first referral center. These are run by trained nurses round the clock and medical officers are on call duty. IV. Referral emergency services. In these centers only first aid is given and the patient are then referred to the health center, hospital according to the severity and need of the case. This type of services is provided by sub-centers, some schools etc. 2.2.4 Importance. The importance of this service lies in the fact that out of all aspects of healthcare, this is considered most crucial and vital, as also perceived by the patient and his attendants, and calls for urgent action. Therefore, not only is the patient life being at stake, but also the image and reputation of the hospital and the healthcare providers. From an administrative point of view, it is one of the most stressful and sensitive areas, which can be a trigger of serious chain reactions hampering the functioning of the hospital. 2. 3. Planning considerations. 2.3.1 Location. As the patients approaching accident and emergency department are in a state of urgency and at the same time minimum time should be wasted in receiving medical care, it is advisable that the department be located on the ground floor with easy access for patients and ambulances. It is best to have it separated from the main entrance of the hospital and easily visible from the road with proper lighting and signs. Proper signposting should be there, and it should be easily located. It is important that ambulance entrance to the emergency department be large enough to admit one or more ambulances. 2.3.2 Space requirements and patient wards. The space required for the accident and emergency department depends upon the number of patients attending in a day, the size and the type of hospital, the type of diagnostic and therapeutic facilities available. Simply stated, a daily census of 100 patients in the accident and emergency services requires 1000 square meters area. To this another 50% i.e., 500 square meters should be added to prevent overcrowding. Patient loads generally show an upward trend in this department and are about 10-15% of total OPD patients. Hence, it is better to plan for overusage than underusage and be prepared for increased patient load. 2.3.3 Physical facilities and layout. In large hospitals, there is a need to have a separate independent department because of large number of patients attending the department. Space for future expansion must be kept in mind while planning for accident and emergency services. Rooms with good accessibility to patients and space for uninterrupted patient flow should be a primary concern. The entrance should be separate with enough space for movement of ambulances and other vehicles. Ramps for wheel-bound patients and slopes with side rails for ambulant patients should be present along with a porch to protect from natural elements. The door should be two-way swinging type for easy flow of patients. Inside the entrance, a waiting hall area should be provided with basic necessities, telephone, toilet, drinking water etc. for the attendants, which helps in decongesting the main treatment area. MSW could also be located nearby the emergency department. It can also be used for triage purposes during disasters. The main lobby should also have facilities for reception and inquiry, and a trolley bay for trolleys and wheelchairs. The main acute treatment area should have the patient cubicles in full view of the nursing station, and should be partitioned from each other with curtains. This area includes the resuscitation cubicles, examination cubicles, pediatric cubicles with benches, etc. One room area should be separately earmarked for observation patients who are likely to remain in the hospital for few hours. Other rooms are required for stores, staff, restroom, OT complex with recovery room, fracture treatment and plaster room, a room for infectious patients, doctors and nurses duty room, staff room and clean and dirty utility room. Investigation facilities includes radio diagnosis unit and an emergency laboratory. For medico-legal cases, a police room and a brought-in dead room are also required. 2.3.4 Architectural design. It is important to remember the principal design follows function in planning of hospitals. The design should be such that there is minimum crisscrossing of patient traffic and privacy is maintained while treating. The room should be spacious, and the joining corridors at least 3 meters in width. Doorways must be designed in a way so as to allow unhindered passage of trolleys. Floor should be non-slippery and wall colors should be of light shades. 2.3.5 Communication. An effective communication system is necessary in accident and emergency department. Communication within the department and to other areas like ICU, support service areas, stores, blood bank, consultants are essential for smooth functioning. Pages should be provided to staff on call for prompt response. Adequate number of telephones. For the staff, telephone with only incoming calls, and telephone for the patient's relatives should be provided in the department. 2.3.6 Component of relationship with OT, ICU, blood bank. Radiology, diagnostic facilities, OPD, mortuary, CCU. For the operational efficiency of an accident and emergency department, the physical and functional relationship with other service department of the hospital has to be smooth and hassle-free. Structure should follow the process for easy accessibility. There must be a very close working relationship between these departments which uses similar equipments, identical methods of medication and require close personal communication. Transfer of patients from one area to the other should be done with the complete knowledge and understanding of both the departments. The accident and emergency department relations with the radiology department of the hospital are very frequent and more in number. So efficient patient flow in the department should be ensured to eliminate long patient delays that are encountered in X-ray examination. Prompt film interpretation and reporting system greatly enhance the efficiency of emergency department. Laboratory services is another important frequently used area by emergency service department. The list of laboratory services available in-house in the emergency department and tests which are to be done elsewhere in the hospital are to be clearly indicated are displayed in the emergency room for the reference of the clinical staff. It should also indicate the type of sample required, method of collection, processing time required for the test and the result. Blood bank or blood storage facilities should be easily accessible to accident and emergency department. Around the clock functional operation theatre, OT, should be within or easily accessible to the accident and emergency department with availability of operating room personnel within a reasonable period of time. Many a times patients are to be transferred directly from emergency department to operation theatre, ICU, CCU. A close liaison and good communication system are absolutely necessary to avoid delay and expedite the initiation of the procedures. The lift accessibility should be nearby the department. Blood bank or blood storage facilities should be easily accessible to accident and emergency department. Thus, a smooth working relationship between emergency department and operation theatre, laboratory and other support service area is essential in order to facilitate efficient patient care services. 2.4 Equipment requirement. In the earlier section we have learnt about the physical facilities which should be available in the accident. Vent mask, nebulizer etc. Cardiac monitors, infusion pump, syringe pump, BP apparatus, minor OT table, transport ventilator, OT light, X-ray machine, boil apparatus, suction machine, dressing drum, instrumental sterilizer, laryngoscope, weighing machine, wheelchair, refrigerator. 2.5 Staffing considerations. It is important that the staff posted in the accident and emergency department should be highly skilled and competent. They should also be of even temperament, calm and oriented to the functioning of the department. The emergency department care staff includes physicians, paramedical staff, and administrative personnel. Each hospital, after careful study, must determine which method of physicians coverage is most appropriate to meet the functional need. One of the most acceptable method and is extensively practiced in our country is the concept of full-time physician in the emergency department. This is also known as Alexandria plan, full-time plan. Another method of coverage that has been in wide use which involves the rotating of staff members, known as Pontiac plan, part-time plan, developed in Pontiac, Michigan, USA. Here the physicians provide the services in the emergency department round the clock, by rotation. The number of each category will depend upon the quantity of work to be provided and the type of the hospital. For emergency department of a district hospital, it is suggested that, based on 8-hourly shift, the following should be the staffing norm. Medical staff, casualty medical officer 1, surgery 1, orthopedics 1, medicine 1, gynecology 1, nursing staff, nursing supervisor 1, staff nurse 5 to 6 per shift, paramedical staff, X-ray technician 1, laboratory technician 1, ECG technician 1, OT technician 1, medical social worker 1, Group D hospital attendant or nursing, orderly including stretcher bearer 5 to 6 per shift, sweepers 2 per shift. The number in each category will also depend upon the quantity of work to be provided. The type of the hospital. In addition to the above categories of staff, plaster technician, ambulance drivers and ambulance attendants are also necessary for efficient and smooth functioning of emergency department. For the sake of continuity and most efficient patient care, staffing of nurses in an emergency service should be permanent members of the department and not rotated from other units in the hospital. The recommended nursing requirement is 7 to 9 nurses per day for each 100 patients in an ideal setting. In a similar situation, the basic physician staffs are to be in the premises 24 hours of every day. In high trauma regions, it is recommended that full staffing is maintained. Even with a lesser number of patient load, all staff members should receive a thorough orientation and training in all the aspects including how to deal effectively with the public. The staff should be able to communicate well with patients and with family and friends who seek relief from fear, anxiety, and pain and in a state of emotional disturbances. 2.6 Policy and Procedures. 2.6.1 Ambulance Services. Generally, ambulance services are considered to be a part and parcel of the accident and emergency department. An ambulance is defined as a vehicle for emergency care, which carries equipment and supplies for optimal emergency care at the scene and during the period of transportation, to provide maximum safety and comfort and avoid aggravation of his condition. You will learn in more details about transportation of patients in Unit 2 of Block 2. Course 5. It has been established through several studies that the speed of transfer of a patient from the site or accidental emergency to the advanced treating center is of utmost importance in saving life and minimizing mortality and morbidity. The golden hour concepts states that a patient has best chance of survival and minimum disability if brought to a center within an hour. It should also be understood that the basic minimum life-saving support equipment like oxygen cylinder, ambu bag, endotracheal tube and airways, foot-operated suction machine, portable ventilator, defibrillator with monitor, immobilizing splints, PSAG, mask and emergency drugs and fluids should be available. In the ambulance should also be provided with two-way communication system so as to facilitate its reaching at the site. This will not delay in obtaining necessary guidance for rendering the pre-hospital care to the patient if required. 2.6.2 Registration and Records. It is mandatory on the part of the hospital to develop and implement a simple and accurate system of registration of all patients who report in the accident and emergency department for care. Manual or computerized registration process can be used. According to the resources, allotting a serial registration number to all the patients attending department. The process of registration should not come in the way of starting the treatment. Proper and meticulous record keeping is absolutely essential, especially in the light of the Consumer Protection Act, which has been described in detail in one of the later units. Most emergency department, the medical record needs to be simplified compared to the extensive inpatient record. It should be designed in such a manner so as to have administrative and basic statistical data about the profile of the patient and appropriate column for clinical information data such as blood pressure, temperature, plus adequate space for physicians and nurses' notes. Generally, the emergency room record should preferably be limited to one single sheet for easy documentation and movement. However, when a patient is admitted to the hospital, the emergency room record accompanies the patient and is made a part of the patient's formal inpatient medical records. When the patient is not admitted, the emergency room record should be retained in the emergency department itself and a copy be sent to the medical records department for proper storage and future reference. 2.6.3 Investigations and Management. All patients attending the accident and emergency department require some or other investigations before any treatment can be initiated. Hence, it is necessary to have an emergency laboratory, radiology unit within or near the department so that these tests can be conducted urgently whenever required. For every patient, the investigation ordered and the results obtained should be mentioned in the emergency records, and copy for same should be retained in safe custody for all medico-legal cases. 2.6.4 Admissions and referrals. Proper treatment should be initiated promptly on the arrival of the patient. Accurate records of all fluids, drugs and medicines given should be maintained in the case records and the treatment register maintained by nursing staff. All the consultations carried out by different specialists in the department should be recorded chronologically and case management done accordingly. During the period of observation, the vital parameters should be recorded along with the time of recording. Whenever consultants, seniors are consulted, their observations or directions should also be recorded. If required, the patient must be admitted in the hospital, and a new indoor patient registration number shall be issued, along with the bed number, ward, and the unit, department under which the patient is being admitted. In case of admission, the emergency record is also sent along with the patient, and it becomes a part of the indoor patient case sheet, which is generally retained in the medical records department of the hospital. However, if the patient has to be referred to another hospital for better facilities, it should be ensured that the patient has been stabilized before the patient is referred. If possible, and patient condition demands, one doctor should be deputed to accompany the patient to the referred hospital. 2.6.5 Medico-legal case. A medico-legal situation can be defined as the one where there is an allegation, confession, or situation of causes attributing to body injury or danger to life. Further, any case of roadside accident should also be treated as medico-legal case. A. All medico-legal cases should be stamped MLC on the face sheet itself on capital letter. All such cases be thoroughly examined and investigated. B. Prompt medical aid should be provided. C. In all such cases, due care for record keeping must be taken, apart from patient treatment. This all relevant information should also be entered into a separate medico-legal register. Filling of medico-legal register are to be in duplicate, so that one copy can be given to police, court, and one can remain in medical record, which are to be used at later date as an evidence exhibit in court during the legal process. Medico-legal register is therefore an important document of hospital emergency service. D. All X-ray and investigation forms should be clearly marked as an MLC case, and it can be done by stamping MLC and kept in one composite document. Case sheet. A. All samples and exhibits of the medico-legal case are important from the court procedure purpose. So items like gastric lavage in case of poisoning, blood, stained cloth or bullet removed from body, arms used in case of fire or semen, stained cloth in case of rape, should be sealed and kept under lock and key till they are delivered to the police, and signature of the police should be obtained in the receipt book. 2.6.6 Emergency drills and codes. Emergency codes. Emergency codes are the codes used worldwide to alert staff for various emergencies. The use of code is intended to convey essential information quickly for understanding, while preventing stress and panic among visitors at hospital. Hospital emergency codes had often varied widely by location, even between hospitals in the same community. Confusion over these codes has led to adoption of standardized codes. List of emergency codes to be used in hospital. Code Red, fire. Code Blue, medical emergency. Code Pink, missing or abducted infant or child. Code Yellow, disaster. Code Violet, violence. Code Orange, chemical spill. Emergency drills. Emergency drill is the activities to practice, develop, evaluate, and improve the plans and procedures on how a hospital or health facilities will respond to emergencies. Emergency drills are done to assess the effectiveness of the hospital emergency response plan, assess gaps and areas that need improvement. For effective emergency response, Emergency Action Plan is there, which is a guiding document for a hospital or health facility during an emergency. It contains the information about the roles, responsibilities, policies, and procedures in response to emergencies. 2.6.7 Triaging. Triaging is the medical screening and sorting, classification, of a number of patients to determine the priority of need for treatment and transportation. This sorting generally results in patients being placed into one of three general priority categories. A. Red, high priority, those who need immediate treatment and have to be shift to ICU or operation theater, e.g., open chest or abdominal wounds. 90% burns, head injury, poisoning, diabetes with complications and cardiac emergencies, etc. B. Yellow, intermediate priority, those who will most likely survive but require treatment and has to be shifted to disaster ward, e.g., burns without complications, major open or multiple fractures, back injuries with or without spinal cord damage, eye injuries, stable abdominal injuries. C. Green, low priority, those who require minimum medical attention like fractures, sprains or strains, soft tissue injuries, minor dressing, etc. and can be sent back home. D. Black, those patients who are unresponsive or brought dead to hospital. Hence, no priority can be given to them. 2.6.8 Emergency Process Flow. Fig. 2.1 Flow of patients in emergency. Look at the screen. 2.7 Monitoring and Evaluation. In the earlier section, there was a discussion about the operation and functioning of the Accident and Emergency Department. There is need of monitoring and evaluation on periodic basis in order to ensure that the most efficient and effective services are available to the community. A study of the utilization of these services should include the data on the number of visits, the average length of stay, the seasonal variation in patient load, the seasonal disease correlation, variations in peak and slack hours and treatment categories. The last variable would help in determining how many treated cases are actual emergencies. The concept of medical audit or peer review must be initiated in the Accident and Emergency Department. Broadly, it involves the review of the medical records of the patients attending the casualty and ascertains the following: the completeness, adequacy, and accuracy of records, the correctness and substantiation of the final diagnosis, the errors in diagnosis and management of patients, the causes of complications and death. 2.7.1 Review, Audit, Committee. It is essential that the appropriate and competent authority constitutes a review or audit committee to conduct this work, as it is of a highly sensitive nature. Senior consultants, belonging to broad disciplines of medicine, surgery, orthopedics, and pediatrics should be member of this committee, along with the Officer of Administration and Medical Record Officer. This committee should meet at regular intervals and take necessary corrective measures by training the staff in order to overcome the future hurdle. 2.7.2 Grievance Redressal Systems. A system must be implemented for the redressal of grievances by the patients, attendants who attend the Accident and Emergency Department. This is more so, especially in the light of increasing number of cases against medical professionals, hospitals under the Consumer Protection Act. Complaint boxes should be strategically located, and every valid complaint should be inquired into, and necessary corrective action must be taken. A senior consultant, faculty member should be made in charge of this forum. It is also advisable to have prominent citizens from other fields as members. 2.8 Summary. In this you have learnt about the changing role and importance of the Accident and Emergency Department in a hospital. You have also learnt about the planning considerations in the department along with the staffing and equipment requirements. A brief concept about the triaging in emergency and about emergency mock drills was discussed. Policy and procedures required for the proper functioning of the Accident and Emergency services have also been discussed, followed with the monitoring and evaluation process of these services. Thank you for watching. We will see you in the next video with the next chapter.